So we find off of hers?
She's able to record, but not us.
Okay.
But
So
she
that's,
has to admit to, so she has control.
Yes,
That's amazing.
yes. So then,
so
now,
then how? So what am I seeing anything on there?
Hmm?
Do I see anything on there then?
if you click on, if I click on, if I click on, click on. There.
Okay.
Yeah, I think I'm in the wrong zone.
Did you have all the slides, right?
Yes.
Okay.
Don't.
Do you want this just in case?
Yes.
Do you want it though, just in case?
Sorry?
Yeah, for sure. Awesome. It's a nice space. We learned after the event that we had here that we needed a mic. So we just released these now. The voice is what we're projecting. I do not know. Okay, so.
You can tell me where to go. Kind of.
Ready? I think I just let you, ready, 1, 2.
Where do we want to be, right here?
Sorry.
All right, 1, 2.
Thank you. Can we get a picture of you with Hope Trap as well?
Thank you, Dawn, and Paul.
You didn't think you were gonna get off that.
1, ready, 1, 2. All right.
Oh, Robin.
Perfect timing.
So just wanting pictures with hope the heart pictures.
With Lucas, hope the heart. Okay.
Absolutely.
Ready? Oh, look at that.
Throw 'em hard. And then Holly and I.
Yeah. And you could also be the straw.
One time.
There.
Oh, cute. That's awesome.
All right. Started shortly, but then we can just make sure that they put their name and phone number for entering the lines of back.
Mike, one. Hello, everyone. We'll begin shortly. Thanks for your patience.
It's already on. Hi, everybody. Yeah, it is on. I never know. My voice is usually so big, I don't usually worry about it so much. So first of all, I'd just like to say welcome to everybody who's here today for our first Congenital Heart Disease Awareness Day. I'm quite excited for the day, and we'll see how it all unfolds. My name is Dawn Barker. I am a nurse that works in the Manitoba Adult Congenital Heart Clinic here at St. Boniface.
My name is Holly Beckering. I'm the clinical nurse specialist for child health and previously worked for 7 years with the cardiac program at HSC for kids.
So Holly and I have been working together now for 4 years, I guess now, Holly? This is not working. Oh, there we go. And we have talked about holding or hosting one of these days for quite some time. And so we're both thrilled that today it has actually come to fruition. So to get started, I would just like to start with a land acknowledgement. So St. Boniface's hospital is located on traditional territories of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the national homeland of the Red River Métis. We acknowledge that our water is sourced from Shoal Lake 40 First Nation. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past. Recognizing that we are all treaty people, we dedicate our efforts towards a more loving and compassionate world as we all move forward in a spirit of reconciliation and collaboration. I am, but cooking's not working right now. Allison!
Okay, do it on the screen.
I'll do it on the screen. See, I'm never worried about presenting. It's always the tech issue. Okay, let's just take this out. Should I just take this out and re-put it in?
It won't let me do it on the screen. It's always a tech issue.
Jeez,
Do you need to do it from mine?
just for sure.
Yeah, but that wasn't working.
It won't let us.
But it allowed me to go from the first slide to the second slide. My apologies, everybody.
Of course, it's working. That's great.
Perfect. Thank you, Elsa.
It's just broke.
Okay, all right.
Hey, minor delay for tech. Okay, so when we're looking at what is congenital heart disease, so congenital heart disease is the world's leading birth defect. There are roughly 1 in 100 Canadian children that are born with congenital heart disease. Previously, like 60 years ago, only about 20% of these children survived to adulthood. Currently, that number is about 90% that are surviving to adulthood.
So what are some common CHD facts? So the Heart and Stroke Association has out and published this year that there's approximately 300,000 people living with congenital heart disease, and that spans across the pediatric and on the adult side. 2/3 of these people are actually adults, and this number has actually increased by more than 50% over the last several years. 50%, at least 50% of the people living with congenital heart disease face a multitude of different issues, whether it's multiple surgeries as a pediatric patient, repeat surgeries or interventions as an adult, once they're an adult. They can have difficulties in school, learning difficulties, mental health challenges, as well as physical challenges.
So when we're talking about national statistics, if you look across Canada, there are 32 congenital heart disease dedicated clinics, 16 for peds and 16 for adults. Most programs don't have dedicated allied health support. There's actually only 2 adult programs that have social workers permanently involved. There's a lack of access to primary care, which also means that your cardiologist is often dealing with a lot of other health concerns that you have. And as many as 1 in 4 children with congenital heart disease will stop going to their CHD clinic by about the age of 6. And when you're looking at adults, more than 50% of adults by the time they're 18 will stop seeing their cardiologist altogether. In terms of local statistics, if you look at the pediatric program, they are working on about a 3 to 6 month wait list right now for new referrals. Most defects require a yearly follow-up. Some are longer than that, some are shorter, but a year is pretty average. And then there is no surgical support and limited diagnostic services within Manitoba. So often we're having to send our families out of province for those things.
And then on the adult side, we have roughly 2,000 patients that we follow in our clinic. 1,000 of those are actually on the active wait list, where we see them, whether it's every couple of months, once a year, whatever we determine. We have about another 200 on our wait list that are new patients waiting to get in, as well as about 800 patients that we have on what we call a re-referral list. So patients that are relatively stable, that don't necessarily require follow-up every year, but maybe every 3 to 5 years, that we want to see that, or that we'll call those patients back in for clinic visits. We have between 60 and 70 patients right now living with a Fontan. Now, I mentioned that just because this is a very high need population. They have complex congenital heart disease, and they are just a very resource heavy population. So it's just important to understand that number that is growing every year.
So in terms of the Manitoba programs, when you look at the Children's Heart Center, it is located in the Children's Hospital at Health Sciences Center. They provide antenatal, pediatric, and transition to adult care. They are one of the founding members of the, and I'm going to get this wrong if I don't read it, Western Canadian Children's Heart Network, which provides surgical support for patients and their families across Canada. And then we see approximately 6,500 patients per year.
And then match clinic, or Manitoba Congenital Heart Clinic, is match. It's not mock, even though we move at the speed of light. It is actually match. We're located here at St. Boniface, not in the Asper building, but in the main part of the hospital. We provide longitudinal care for people living with congenital heart disease. And we're really only one part of a multidisciplinary team that manages this patient population. We work very closely with respirology and hepatology for some of our more complex patients. We have about 100 patients a year that transition from the pediatric world over to the adult world, and this number is only continuing to grow. The adult world has actually increased by more than 50% over the last 10 years or so, whereas the pediatric population has increased only by 11%. So our numbers are going to continue to grow, and these people are living with this their entire life. So it's not like we can say, oh, well, too bad, we're not going to follow you anymore. And as I said before, we're following about 2,000 patients, which is about a 68% increase since 2012.
So why are we talking about transition? Well, we've acknowledged that there are more and more patients that are living with congenital heart disease throughout their life. This isn't just a pediatric issue. We are following them. So the idea is there's no cure for congenital heart disease. This could have an impact through any point in your lifespan. So we need to build a better transition program to carry these kids through onto the adult side. The idea of transition is that you're supposed to start at a younger age. You go from a very family-focused, kind of parent-organized approach to a spot where we're hoping that kids are going to take more responsibility, more ownership of their healthcare. And it's part of the process of transitioning them is to help them learn how to do that. So the goals of or I should say the factors to a successful transition are things like health knowledge. So kids knowing what their defect is, the impact it can have on their life, their limitations, those sorts of things. Looking at self-management, are they able to do things like book their own appointments, reach out to their own pharmacist, manage their medications, those sorts of things. And then things like self-advocacy. So if there is a shortage of resources in their area, do they know how to advocate for themselves to get those things in place that they need to keep them healthy?
I just have to say that is one of my favorite pictures on this entire presentation. It's just so darn cute. So challenges.
So in terms of challenges that we face with transition, it's not uncommon for a lot of our pediatric patients to go through a very long period of stability through their childhood. So sometimes it's been 10 or 15 years since you've had an intervention, and congenital heart disease kind of slips off your radar for things that you're dealing with. And that's part of the reason why they don't necessarily recognize the need to have adult congenital care as they go through that transition process. There's also a lack of awareness about congenital heart disease resources within Manitoba. And really, we found that across Canada with other groups as well. There's high workload demands and limited staffing on both sides of the program for kids and adults. This is a very high resource need population. There isn't necessarily dedicated allied health to go with the programs. On the pediatric side, we have been very blessed that we have heavy social work involvement, and that's been consistent. There's a lot of programs that don't have that kind of support. And the other thing is that the chronic nature of congenital heart disease often leads to impacting other parts of your health, and that can kind of all pool together into making these high needs patients.
So with every challenge, there always comes success. I think it's very important that we always focus on a lot of the positives that we certainly do see on a regular basis. One of them is the publications that the physicians have done across both programs. All of our docs, I think, have multiple publications out there trying to raise awareness in the world of congenital heart disease. There's numerous research initiatives, again, across both programs. Here at St. Boniface, we're currently working on a CAN-PONS registry for our Fontan patients, as well as a MYSTIC study, again, for our Fontan patients. And we have a couple of other smaller studies that we're still involved in. We also have had education events like what we have here today. Back in, it's a little bit of a typo, my apologies. We had our first ever Fontan Day in November of 2023. That was quite well received. And then the success that we've been seeing with our combined transition clinics. Holly and I have been working, as we said before, for the last 4 years on this. And every time we go there, we're just constantly evolving it and trying to make it better. We still have a long ways to go, but we're certainly on the right path, I think.
So things we're looking at in the future. I have talked with a couple of you today already about our hopes in starting the transition process earlier. So currently, based on our resources, we've been transitioning people kind of right around the age of 18. Ideally, we would like to bring this topic up around the ages of 15 to 16 so that we have a few visits to talk about it and kind of build in that process. We would like to raise awareness overall of congenital heart disease and have people understand that this is not specifically a childhood thing. This does carry through into adulthood and has its own implications as you get older. And then we would like to build a stronger team around our patients and their families. So build those resources in place, especially things like allied health on both sides of the program.
So just thank you to everybody that supported us here today. And with that, we're actually going to get going on our list of references if anybody's interested on our presenters. So we have a whole list of different presenters here today. Some people from the pediatric side, from the adult side, and we have a patient with a lived experience, and then as well somebody from Circle of Hearts that will be talking with you guys today. So I'll get the slides going and you can introduce our first presenter.
So we're going to start with the little ones and then work our way through. So my first presenter is from the Children's Heart Center, Pam Reimer. She's worked at the Heart Center for worked at Children's Hospital for 32 years. Sorry, not just the Heart Center. In both the neonatal ICU, the pediatric ICU, and then the last 23 years has been in pediatric cardiology. So her current role is surgical nurse coordinator. She sells herself short. She does a lot more work than that, I will say. She's involved in coordinating surgeries and diagnostic procedures at the province. She helps families through this process both before surgery and after. I've lost my face on the page. Her position is closely aligned with social work in terms of planning travel and accommodations, manage all of those things. She also works closely with social work in terms of fetal diagnosis, introducing families to NICU, talking to them about their diagnosis, what their heart journey might look like, those types of things. She's also actively involved in the Western Canadian Children's Heart Network as part of the Nurse Coordinator Committee and their Integrated Advisory Board. She is very passionate about her role in pediatric cardiology and enjoys having the opportunity to help patients and their families navigate some of the most difficult journeys of their life. Welcome, Pam.
Well, thank you for the organizers for inviting me here to speak today. And thank you, Holly, for that very lovely introduction. I feel very honored to represent pediatric cardiology here in Manitoba. As Holly said, I have worked at the Children's Heart Center for the past 23 years, and I've had the opportunity to work with many children and their families as they navigate their journey with congenital heart disease. Hopefully, my presentation today will just raise awareness that CHD is a lifelong condition that may impact not only the child's life, but also their families well beyond just their medical needs. Here's a nice slide of our brand new, fancy Travis Price Children's Heart Center. We were fortunate a few years ago in 2021 to move into this new space. So we are located now at the Children's Hospital. If any of you are familiar with Health Science Center, there's a lot of buildings there. So to locate us, look for the helicopter landing on the roof, and we are the 4th floor of that building. So looking at our program, as a general overview, we provide pediatric cardiac care throughout Manitoba. So this is from birth to age 18, as well as the Kivalliq region of Nunavut and Northwestern Ontario. So we have a very busy outpatient clinic where we see around 6,000 patients a year. We also provide inpatient services to our kids when they get admitted into Children's Hospital, as well as the newborns in the NICU at HSC and the newborns in the NICU at St. Boniface. Our team in the past has had some staffing shortages as far as cardiologists, but since 2012, we've been blessed to have 4 consistent cardiologists in our program. We have Dr. Shantz, Dr. Peplasis, Dr. Soni, and Dr. Bufo. And we do provide many services. We see patients every day. We have clinic Monday to Friday, 8:30 to 4:30. So it's always a full waiting room. We also are now up and running in our cath lab. So we perform mostly diagnostic caths as we don't have surgical backup. So we're limited to the type of interventions we can perform in Manitoba. We have an active electrophysiology program, including Holter monitors, pacemakers. We also have a cardiac MRI program for peds. We have a dedicated MRI scanner for pediatrics now. We have a very busy fetal cardiology program, which I'll talk about briefly, and also a very active cardiac transplant care program. And I forgot to mention outreach. We also have outreach clinics where we take our team and travel up north to Thompson, St. Teresa Point, and all the way as far as Arviat, Rankin Inlet, and Nauyet. Here's a lovely shot of our much younger cardiologist, a picture of their choosing. On my left, we have Dr. Shantz, Dr. Peplasis, Dr. Soni, our section head, and Dr. Bufo. Somehow they picked that slide. So in addition to general cardiology, they also all have a subspecialty. So if we start on the left, we have Dr. Shantz, whose main subspecialty now is cardiac MRI. He also is our sole doctor that goes to the outreach clinics in Nunavut and St. Teresa Point. Then we have Dr. Peplasis. He is our interventional cardiologist. So he is the only cardiologist that performs heart caths here in Manitoba. Thirdly, we have Dr. Ilan Bufo, who is our arrhythmia specialist or electrophysiologist. He also goes to outreach clinics in Thompson. And then lastly, we have Dr. Soni. She is our section head, and she specializes in the care of our transplant patients, both pre-transplant and post-transplant, and is also the only pediatric cardiologist in Manitoba that specializes in fetal cardiology, which is another very busy program. She scans on average about 120 women per year. To complement the doctors, we need some nurses. So we have 3 nurse clinicians at our center. So myself, Pam Reimer, and my portfolio is the out-of-province surgical coordinator, the out-of-province cath coordinator. I am actively involved with our network of the WCCHN. And when and if I have some time, I might work in the cath lab as well as a scrub nurse or circulating nurse. In the middle, we have Amber Duchek. Amber is our cardiac transplant coordinator. So she works closely with Dr. Soni to care for our transplant kids, which we currently have 14 patients in our center that have heart transplants and 2 that are waiting. So that's a very busy portfolio right there. She also is the only pediatric pacemaker nurse in Manitoba. So now our kids with pacemakers can come have their devices checked at our clinic and saves them 1 more trip to St. Boniface. That's been a nice addition to our portfolio. She also coordinates any EP services these children might need out of province, such as radiofrequency ablations. And then our third nurse is Steph Sire, and she is our cardiac cath lab coordinator. She coordinates our cardiac MRIs, and she is now kind of merged from Holly's departure in our adult transition coordinator. So she'll be working with this team as well. We have a fine group of cardiac technologists. We're lucky to have 5 dedicated sonographers and 1 EKG tech. So they're a busy group as well. They cover all of our outpatient clinics, our echo lab, our ECG lab, our stress lab, our Holter lab, inpatient care, the cardiac cath lab, and they also go to the outreach clinics. And as Holly mentioned, we are extremely blessed to have our own very dedicated full-time social worker named Erica. She's new to our program and has been a fantastic addition. Erica often meets our families at the very beginning of their journeys, often when they have a fetal diagnosis. She provides support to our families when they're receiving a new diagnosis and are going through some pretty tough times navigating the care that their child will need. Often that involves going out of province. As Holly mentioned, we don't have pediatric cardiac surgery in Manitoba, so the care is in other provinces, mostly in Edmonton and Vancouver. So Erica works very closely with our families, supporting them through this, everything from giving them a hug and telling them they're going to be okay, to booking their plane tickets, their hotel, and giving them maps and directions. She collaborates with the other healthcare team members to address any barriers or psychosocial factors the family might face. She offers counseling and therapy if needed. She assists the families with financial planning and sometimes their eligibility for some of the government services and benefits that families are entitled to. She also is key when we facilitate transitions between healthcare settings. If we have patients that have been out of province for a while and they're transitioning back to Manitoba, can often be a time that's very tough for families as well. There's a nice little photo of our group in our waiting room under our tree. Just kind of the highlight of our waiting area. This here is a little slide kind of demonstrating the growth of our program over the years. So the line there begins in about 1997 when we were seeing just over 1,000 patients per year in our outpatient clinic. This graph cuts off at 2019. Clearly, we're still in business. So now in about 2024, we are seeing just over 6,000 patients per year in our outpatient clinic. So we are very proud to say that despite these increasing volumes and our limited team, our wait list for elective referrals remains about 3 to 4 months. Here's a little slide kind of marking some of the milestones of our program. So this begins in basically 1995, where the pediatric cardiac surgical program was shut down here in Manitoba due to the number of deaths that were happening post-surgery. So since that, in 1996, was kind of the creation of a very informal out-of-province program because these kids still needed surgery. This was followed by the year 2000 when Justice Murray Sinclair released his formal cardiac inquest report, which is public knowledge and can be found on the internet. In 2001, our formal network of the WCCHN, or the Western Canadian Children's Heart Network, was established. In 2001, we were successful in our very first pediatric ECMO case. ECMO, for those of you who don't know, is basically a life-saving heart-lung machine that stabilizes the patient until we can get them to the surgical site. In 2002, we officially started caring for our transplant patients here in Manitoba. Previously, that care was done in Edmonton. Dr. Soni took that over in 2002. In 2004, we formalized our fetal cardiology program, where we now receive referrals from obstetricians, GPs, nurse practitioners all over Manitoba. If any woman has had an unusual scan, say at around 20 weeks, and there's something concerning regarding the heart, we'll get a consult, and Dr. Soni now scans these new moms at around 22 weeks gestation. In 2006, our official Circle of Hearts Family Support Group was established. In 2008, we were able to establish our new pediatric arrhythmia program. In 2009 is when we started being able to see our pacemaker kids at our own clinic. 2013, we started doing outreach clinics in Thompson, followed by Nunavut and Rankin Inlet in 2014. In 2017, our new MRI scanner was up and running, and we were able to do our own cardiac MRIs here in Winnipeg. 2020, our brand new cath lab opened. 2021 was when we moved into our brand new building at the Travis Price Children's Heart Center. In 2022, we established our own Holter program where we're able to put on our Holters, read them in our clinic, and get results back very efficiently. And in 2023 is when we started doing our joint transition clinics with this team from St. Boniface. Man, that makes us sound old. So a little slide of our catchment area doesn't show up very well, but as I mentioned, we do cover all of Manitoba, all the way up to the Kivalliq region of Nunavut and into northwestern Ontario. So from Winnipeg, we have patients that are about 2,000 kilometers to the north and about 750 kilometers to the east. A lot of these communities where our patients live are either air access only or sometimes ice road access only, which does complicate things. These slides are not showing up. My apologies. Never mind, there it is. This slide demonstrates the population of our single ventricle patients, which are one of our more complex grouping, known as our hypoplastic left heart kids or hypoplastic right heart kids. So this slide demonstrates 67% of them are actually from in and around Winnipeg. The orange markers indicate patients that are driving distance from Winnipeg, and the purple markers are the ones that are from fly-in only communities. So when we talk about congenital heart disease, this is something that can be diagnosed even before the child is born. As I mentioned, in 2004, Dr. Soni officially started the fetal cardiology program, which led to advanced prenatal detection and early diagnosis. This program offered a huge improvement. And from this slide here, you can see that prior to the program, there was 30% of defects that were being picked up antenatally, which has now increased to 88% that are being diagnosed antenatally. This is a huge accomplishment because this early diagnosis causes a huge reduction in the perioperative instability of these kids. When we're able to make a fetal diagnosis or antenatal diagnosis, we're able to ensure that that baby is delivered at an appropriate healthcare center with quick access to our program and our services, and then on to the surgical sites. We want to make sure that none of these babies are being delivered in those remote communities, which could put their child in harm just because of the physical distance that they are from our center. A little blurb about our past. As I mentioned, in the past, we did offer heart surgery for pediatrics here in Manitoba. That was shut down in 1994, as I mentioned, and that's just a summary of the Manitoba inquest. As I mentioned, once the pediatric program was shut down, we had to send our kids somewhere for heart surgery. So it was kind of a very unorganized system. We were sending kids to BC Children's, we were sending kids to Stollery in Edmonton, we were sending kids to Toronto Sick Kids, we were sending kids to Montreal. So basically they were being fanned out across the country with no formalized way of making referrals. This very unorganized system then gave birth, once we started looking at the bigger picture, to a network. So the events of the cardiac inquest highlighted the risks faced with high-risk kids in low-volume centers. The preliminary negotiations started in about 1995 between the Western provinces about the idea of formalizing some kind of a network. Manitoba spearheaded these discussions for about the first 15 years until finally there was approval at the deputy minister level between the four provinces of BC, Alberta, Saskatchewan, and Manitoba to officially form our network, now known as the WCCHN, or the Western Canadian Children's Heart Network. So this network basically brings together 5 children's hospitals across 4 provinces, all with one goal, and that's to provide world-class cardiac care when it matters the most. The WCCHN is North America's only regional care network that's dedicated exclusively for children with heart conditions. So the 5 centers that are in our network, we have 2 surgical sites, one being in Vancouver at BC Children's Hospital. The other surgical site is the Stollery Hospital in Edmonton. The other 3 hospitals are considered referral sites. So we have the Alberta Children's Hospital in Calgary, we have the Royal University Hospital in Saskatoon, and our Winnipeg Children's Hospital. So the development of this network allowed us to streamline communication with our surgical centers. We are now able to have very official way of referring our patients. An interprovincial database was created So we could seamlessly refer our patients electronically, transfer information electronically in a safe network database that was shared between the centers. We also have currently a weekly joint surgical conference every Tuesday with all of the centers online, where patients are officially presented for surgery. Their cases, everything is reviewed digitally, and it's a very collaborative approach. It's like having about 20 or 30 different opinions, second opinions, all in one room. So it is a very good and healthy system where you have the collaboration of some of the best across the country. This graph just shows the improvement in the survival rates post WCCHN era. So in the early 90s, our mortality was at about 12%. That has now decreased to about 2%. This slide highlights, again, one of our most complex congenital heart defects known as hypoplastic left heart syndrome, or sometimes we refer to it as single ventricle physiology. Pre-1985, there was nothing to offer these children. They were merely told that they wouldn't survive, handed to their families, and they would pass away, usually within the first week of life. Over the years, with the advancement of surgical techniques, a 3-staged surgical approach was developed, and now there was something to be able to be offered to babies that were diagnosed with HLHS. And by 2023, we've gone from 100% mortality to a 5% mortality after their stage 1 surgery, which is usually performed in the first week of life. All of our surgical results are available in the database under the Thoracic Surgeon Society, and we have been labeled as having the best single ventricle surgical results in North America. To make this feel a little more personable, this is the story of my little buddy, Caleb, who was born with hypoplastic left heart syndrome. He was actually diagnosed, or his mom was diagnosed antenatally. So they kind of walked this entire journey with our team. This photo here is Caleb going into his 2nd stage surgery known as the Glen. He was about 7 months old in this picture. Oftentimes we use these photos as a teaching mechanism to kind of prepare families about how their child will look the first time they see them coming out of the operating room. I always say I don't use this photo to scare you or to freak you out, but I use it because I firmly believe that knowledge is power. Here's my little buddy on post-op day 3, sitting up, a few tubes less, and almost smiling. So kids are fantastic in how they can bounce back. And there's a photo of him 3 months later at 10 months. And my favorite photo is his first day of kindergarten. So we've spent a lot of time talking about successes, but we also have to realize there's a lot of long-term concerns with this population of kids with CHD. The list is long, the complications can be quite advanced. I'm not going to go over this long list, but definitely this ties into our need for adult transition because these concerns are lifelong. Raising a child with CHD poses many challenges, such as quality of life issues for the child and their family, neurodevelopmental issues, family struggles, both financially and other ways. Then there's the bittersweet time of transitioning to adult care. As I mentioned, a lot of our families have been with us since birth. They get to know our team very well. We walk through 18 years of their life with them, and then we tell them bye-bye. It's hard not only on the child, but also on the families. It's a very unsettling time with a lot of anxiety. Which brings us again to the importance of transitioning all of these precious patients into the adult world. The goal of our transition clinic is to improve the experience of patients and their families, hopefully reduce their anxiety, and ultimately improve their medical outcomes. Since offering our joint clinics in 2023, we've received very positive feedbacks from our patients and their families, very appreciative in how we have tried to ease this transition. So we now offer joint clinics at our Children's Heart Center where the St. Boniface team comes over, and the child is seen by both their pediatric cardiologist and their new adult cardiologist, as well as Dawn, the nurse who comes as well. This has been fantastic and very reassuring for families to know that these two people are talking to each other and that that information is being passed on directly. So our goals, again, is to optimize communication between the two centers. We run those clinics every 3 to 4 months. We do usually start these transitions when they're 17 or 18, but definitely a future goal is to start this process much earlier. Our newly implemented system is digital, which means that all of their ultrasounds, their echoes that have been done throughout their year are now on one shared drive that can be accessed by the pediatric team and the adult team, which again adds for a lot more seamless communication. There's a lot of research collaboration going on now between the two programs, as Dawn mentioned, offering some Fontan education days. This is a high-risk population, and some other collaborative areas of research as well. We're hoping that in the future there will be more of these joint days, because I think they are extremely important. So with all the challenges, we have to have some kind of creative solutions. So over the years, and I'm just talking from the pediatric program, some of these solutions have been the creation of a family support group where families can talk with each other, lean on each other, support each other, cry with each other without medical professionals being in their way. There's a dedicated youth group where kids can meet other kids that have scars and find out their stories and their struggles. There's a peer-to-peer support program where sometimes we link families together, maybe families that have had a similar diagnosis or a similar journey, to help and support each other through their process. We've been able to have some point of care monitors for a lot of our kids that are on long-term anticoagulation. There's a lot of blood draws and trips to the lab. We now have special monitors they can have at home, which is just a finger poke as opposed to being driven to the lab and having their blood drawn. Our transition clinics with the adults is an excellent solution. And also our WCCHN has a program to follow their neurodevelopmental conditions as they age over the years. The children are automatically registered into this program when they're born, the complex ones, and they're followed by a developmental pediatrician at age 6 months, 18 months, and then prior to entering kindergarten, just to assess any needs that the child might have and to get some resources put in place prior to them starting school. Here's a great photo of this awesome group of CHD survivors. This was taken just this past summer at a summer camp at Brereton Lake. These are truly our heart heroes. Thank you.
Thanks so much, Pam. That was an absolutely fantastic talk. Now, does anybody have any questions for Pam before we move on to our next presenter? Okay. So just as a reminder, make sure you guys enter in for the door prize. There's coffee and water in the back, and make sure you help yourself to some of our handmade congenital heart cookies on your way out as well. Sorry, tacked again. Do you want to do this, Holly, while I introduce the next one? Okay. So up next, we have Dr. Robin Dukas. So Dr. Dukas completed her internal medicine and cardiology training at the University of Manitoba, earning her FRCPC in cardiology in 2014. She then pursued specialized fellowships in adult congenital heart disease, maternal cardiology, and echocardiography, which makes me tired just thinking about all of that, at the University of Toronto and Mount Sinai hospitals between 2014 and 2017. In 2018, Dr. Dukas joined the section of cardiology in the Department of Medicine at the University of Manitoba. She is the Assistant Professor of Medicine and Obstetrics, Gynecology, and Reproductive Sciences, and has served as the Medical Director of the Manitoba Adult Congenital Heart Program here at St. Boniface. Now, I've worked with Dr. Dukas over the last 4 years, and I can honestly say her passion for CHD shines through with every conversation or discussion that we have, whether it's directly related to patient care, patient advocacy, or ways to improve the landscape of those living with congenital heart disease. We are lucky to have her as a leader in MATCH. Please join me in welcoming Dr. Dukas.
I need to be more mobile, so I'm gonna grab this and go. So, my talk is a bit more of a masterclass, I guess, on congenital heart disease. Hopefully we all learn something today. It's coming from a very medical background, so you'll have to forgive me if this feels a bit like a university lecture, because it is. So what are our objectives? So today, what do I want you to leave here knowing? Well, I'd like you to be able to describe the basic terminology of adult congenital heart disease. Why? How we describe our language in medicine, how we care for people. We're going to cover three basic classifications of congenital heart disease and how they can predict morbidity and mortality, as well as the general principles. You should be able to describe the general principles when considering care of patients with adult congenital heart disease. So in the beginning, there was nothing, and by nothing, I mean there was no care for congenital heart disease patients, and then that exploded. So to give you a bit of an understanding of why congenital heart disease is important, it's really important to understand that it is new. The first descriptions of congenital heart disease actually were in the 1500s. And this wasn't in a living patient. And you may be surprised to know who was the first person to describe congenital heart disease. Probably a couple people here who've heard of this person. Some people might actually know when this happened. But it was Leonardo da Vinci. He was doing his illicit graveyard anatomy lessons and discovered that in some people, there were holes in the heart that weren't in most other people. And so this is where the description of abnormalities present from birth began. And over the years, more and more people noticed these in pathological examples. It really wasn't until 1800 that physicians were able to say, okay, this person has a clinical problem and it is likely related to a heart problem that they have. So there's a big gap between finding this in anatomy specimens to diagnosing somebody clinically. Unfortunately, when they diagnosed somebody clinically, there wasn't much they could do about it. So you may know Sir William Osler is a very famous Canadian physician. He wrote a huge textbook going over many, many different lesions and medical things in Canada. And he had dedicated a few pages to congenital heart disease and basically summed up all of his findings that congenital heart disease only had a very limited interest, as in a large proportion of these cases. The anomaly is not compatible with life, and there is nothing that can be done to treat the symptoms. So we went from understanding it was a problem to being able to describe it clinically, but having this feeling of hope. There's nothing that we can do. We all know that changed. But it really required a few other medical advances to change. And that really comes with our expert cardiac repair. So there are congenital heart lesions that we could treat by doing things outside of bypass surgery of the heart. And that was only possible when cardiac anesthesia became a reality and it was offered in hospitals. When cardiac anesthesia, when the ability to put somebody to sleep, to do a procedure on them without causing them excessive pain was possible, we could then repair some of these lesions. And that happened in the 1900s and 1940s. So huge gap between identifying a problem, clinically describing it, and actually being able to do something about it. And so that first lesion, if you don't remember this, I won't fault you for it, but was a ligation of a patent ductus arteriosus. This is a lesion present from birth that should go away, doesn't always. And one surgeon was able to tie it off and fix the problem. Other lesions that were able to be operated on is they could connect the extra blood vessel to lungs that were too small and help those lungs grow. That's the BTT shunt. The first actual heart surgery, interestingly enough, this is heart surgery ever, was in an adult congenital heart patient. This was a Dr. Gibbon in the United States who operated on a bypass machine. And his first patient was an adult woman who had an atrial septal defect. So not only is congenital heart disease a relatively well-established pathology, something that's been characterized clinically, but it has led the way for lots of the bypass surgery that we do today. This is Dr. Gibbon and the first patient that he operated on. So now we have our extracardiac repairs and our intracardiac repairs. And 1950, a lot of you here are quite young, but 1950 wasn't that long ago, medically speaking. That's quite new. And so that was fixing simple defects in the 1950s. And then we come to the 1980s, where we're now able to fix more complicated lesions. And this is part of the reason why survival with patients that are born with congenital heart disease has improved so much over the years, because over the years, our surgeons and our medical teams have been able to do and offer more to people. And so these are the surgeries that they came up with in the 1980s during our single ventricle repair. So single ventricle repair, only one heart pumping chamber repair. which can be done through an older technique or a newer technique with grafts. But very, very complicated surgeries, very, very complicated hearts, but now have options for treatment. So historical perspectives, 1950s, we talked about it, 1980s, sorry, 1500s, we talked about it, 1800s, we described it in living people. And then in 1900, we were actually doing something about these things. And later on, 1980s, our more complicated repairs are established. And that brings us to some of the amazing things that happened in that time. I glossed over quite a bit of it, but this is one of the early surgeries for repair of tetralogy of Fallot. It's a lesion where babies are born blue. And what I hope everybody can appreciate in this image here is there's a bunch of doctors and nurses looking at the patient, sitting right here that they're operating on. Look at this picture long enough, you'll notice that there's also some doctors looking over here at another patient. What this is a child with tetralogy of Fallot who is connected up to his father as a bypass machine. And the reason that I show you this is that it explains the lengths that people went to try to repair these lesions. It was, in past times, these lesions could be considered a death sentence, a very, very reduced life expectancy because of it. And so surgeons, nurses, allied health, all have made major steps to try to repair these lesions any way they thought they could. So across the circulation, double patients. A lot at stake here. Okay, so that's great. That's what happened before. What are we doing right now? Well, we've done a lot of things. The key points that have already been brought up, and if you look at the heart stroke information that's out now today, is that 1% of all life births have congenital heart disease of some type. 90% survival to adulthood now, which is amazing. But survival to adulthood, it's a miracle. 18 years. I don't think it's enough. I think we can do better than just hitting 18 years. There are way more adults now than children with congenital heart disease. That is something that is a bit of a misconception. Adult congenital heart disease is the bulk of the congenital heart here in Canada and around the world. And we have increasing morbidity and mortality that we need to deal with in the medical team. So I'm going to give you some quick foundation on it. Usually if we talk about adult congenital heart disease in terms of defects that are present from birth. So it is something that you don't acquire, it's something that you have since when you're born. That could be persistence of a normal structure, so a connection between vessels that doesn't belong there when you're an adult or when you're out of the womb. It could be an arrest at a normal stage of development, so instead of forming a nice muscle septum there, there's a hole between the pumping chambers, or it could be something truly malformed. So the vessels here are switched. And if you don't remember all these pictures, that's fine, but these are the general concepts that can happen for congenital heart lesions. But there's a huge variation in congenital heart disease. About 2% of the population has a bicuspid aortic valve. So this is a valve that acts like the door between the main pumping chamber of the heart and the vessel to the body. 2% of the population has bicuspid aortic valve. Instead of 3 leaflets, there is 2. That can present in a 99-year-old, incidentally, if we hear a murmur, or it can present as hypoplastic left heart in a fetus that's diagnosed neonatally. So same problem, very different scenarios. And also, if you learn nothing else from this talk, is that surgery is not a cure. We do not cure anything in congenital heart disease, we manage it. Long-term outcomes from atrial septal defect patch, so a hole between the top chambers of the heart, is usually pretty good, very similar to an age-matched population. When we're getting into more complicated repairs, there's long-term complications that can happen. We've got valve conduits with bigger pouches, and then patients that have single ventricle physiology or one pumping chamber, there's more problems that they end up experiencing compared to people that have less. So when we classify congenital heart disease, we really like to break it down into groups of simple lesions, moderate lesions, and complicated lesions. What's important for everybody to know is just because you're simple does not mean that you're going to have a simple clinical course. For the more modern and complicated types of defects that we see, higher risk for long-term complications generally. What I tell my trainees is that if somebody has congenital heart disease that's complicated is if their repair is named after a radar. Just to show you some examples of simple atrial septal defect, hole in top chambers, ventricular septal defect, hole in the bottom chambers, and patient vector arteriosus, connection between 2 blood vessels. Fairly straightforward lesions that we repair and see in clinic day-to-day. We can have more moderately complicated lesions. That's where you have abnormalities of valves not growing properly, bigger holes in the heart, or connections and narrowings of the great vessels coming off the heart. And then when we look at even more complicated patients, this is where we have single ventricles, so only one pumping chamber works, only one big blood vessel coming off the heart, or sometimes the heart's backwards, and that does happen. But the reason I show all this is because if you put this into context of the timeline of surgeries we talked about, holes in the heart, atrial septal defect, 1950s, tetralogy of Fallot, so it's pretty common cyanotic lesion was repaired in 1950s. 1960s, we have more complicated repairs. 1970s, single ventricle repairs. And then we get into the 1980s, that's 1979, that's our most complicated surgeries. In 2025 now, there are variations in these techniques, but a lot of it now is the care of adults and how we manage these lesions that have been repaired very recently, medically speaking, as they get on to adulthood. And I promise not to show too many graphs, but I'm a doctor and I like graphs. So this is data from Canada showing the number of congenital heart patients that are adults in red and the number of that congenital heart patients in blue over the years. And what I want you to take away from this graph is that since 2000, at the very least, there have been more adults with congenital heart disease than kids. And that number is increasing. And it's gone up by about 57% since 2000. So the bulk of the congenital heart patients in Canada are adults. When we look at survival to adulthood, there's different numbers that come over time, but essentially, if you have mild disease, so those lesions I talked about earlier, the survival to 18 is about 98%. If you've got moderate lesions, you're looking at a survival of 90%, but we still have work to do with the complex lesions. Doesn't show very well, but the survival to adulthood is lower. Now, this is improving year to year, but there is a difference between complexity groups. And overall, when we look at the general Canadian population, this is data that's a little bit old, but it is estimated now that there is anywhere between 260 to 300,000 Canadians with congenital heart disease. That is a huge number. It far outpaces many of the other lesions that you hear in the media. And when we look at, okay, well, where are these patients? What are they? How old are they? What's the population look like? It is a very young population. We're talking about people that are predominantly in their 20s, 30s, and 40s. Now, we are getting geriatric patients with congenital heart disease, but the bulk of the congenital heart care in the adult is going to be usually between 20 and 50. They're young. And what can go wrong? We always hear about death. It is something that is very quantifiable, and it is something that we need to talk about and be aware of. But depending on the lesion, the median age of death or your survival is going to be reduced. This is because cardiac surgery is not a cure. When we look at what people die of, a lot of the times it's heart-related, heart failure, type of arrhythmia, or even in the perioperative setting. So these are all areas where we target therapy and prevention. What's also important from a hospital point of view is that the cost of congenital heart care in the adults has been increasing. So this graph here, this is fiscal year, only up to 2012, so a little bit of older data, but what we can see is that the cost for adult congenital care is slowly increasing, whereas the cost of pediatrics has been relatively stable. And part of this is because there's more adults with congenital heart disease. So the hope is that if we can improve their outcomes, we can reduce healthcare costs for them. And admissions to hospital. I'm going to skip over this slide. Now, in order to address all of this, there have been many guidelines that have come out recommending how we treat patients with congenital heart lesions in the adult. Starting in 2008, most recent one was the Canadian guidelines in 2022. But a lot of work has been done in this space to standardize care because it has been very clear that there's way more people out there than we're able to care for in our specialized clinics. There's an increasing prevalence, more and more patients, and not only are there more patients, they're getting older, having pregnancies, or having other surgeries, there's more healthcare needs. And we know that there's an increased morbidity and mortality, which is leading to hospitalizations, need for reintervention, and heart failure. So we are trying to address some of these things, and they have. So this is data also out of Quebec. What I really want to get at with this picture is this is survival, and this is guideline publication. More patients survive when they're cared for in a specialty center after we have our advice or guidelines for their care coming out. So we want to look at this in a very simple way. If you have specialized congenital heart disease care and you are followed at a referral center that manages patients with congenital heart disease, you will live longer and there will be less death than if these patients are cared for a center that does not manage patients with congenital heart disease. So this boils down to there is evidence that managing and following guidelines and having specialty care saves lives. So who should be seen at a specialty clinic? Well, ideally, everybody that has congenital heart disease should be seen at least once. Not everybody needs to be followed every year, but ideally having an adult congenital heart disease once. For some lesions that are simple, a shared model of care, so having a primary care provider or a general cardiologist and a congenital cardiologist can be a great model. For people that are more complicated, they may require more admin. And also, it's important for patients and people and care providers to understand higher times of risk. So if somebody has congenital heart disease, is having a pregnancy, they probably should be seen by the specialty clinic. Or if they're having a major surgery for non-cardiac reasons, that would be another. Part of the problem is that the population has outgrown the resources available, and that there aren't enough specialized physicians. It takes 9 years to train one of us. That's a long time. So if we decide we need 10 more, it's a long time to train those people. There's also not enough specialized nursing and hospital support, but hopefully with more advocacy, that's going to continue to grow. One very important thing that makes me worried is the loss to follow-up. So resources aside, if we have people out there have congenital heart lesions and don't continue on getting care, they're at increased risk for having bad outcomes. Some of these loss to follow-ups, big time at risk is transition from pediatric to adult care, and that's part of the reason why we're so passionate about it. So I'm going to give you just a little bit of data from Manitoba. We did a local project between 2008 to 2017, where we looked at the old way of doing referral from pediatric to adult care. The old way of doing referral from pediatric to adult care was the pediatric cardiologist said, this is your last visit. They sent a letter to the adult cardiologist, and the adult cardiologist put them in their plan. And that was our whole process for transition. You can imagine it did not go as well as it could have. But what we found is that we had about 650 patients that were transferred from pediatric to adult care. Some of those were delayed or went to other provinces. So out of the 550 patients that were referred to the adult clinic, we found that 72 of them just never came for their first visit, never showed up. We found of the people we saw at least once, 130 of them never came back. That meant that in that process, going from I've been followed for 18 years or however through pediatric cardiology, then referred to the adults, almost 40% of them don't have ongoing care. So that's a big deal for us. We would love to be able to have everybody in ongoing care, or at least know they have a cardiologist that can follow them to help them when they need. So our general principles, how to approach it from a medical point of view, you need to understand the anatomy, and the healthcare providers looking after these patients, people need to understand the anatomy. We need to know what can go wrong and when. We need to understand what was repaired and what to look for over time, and how to communicate that with families, understand those long-term complications, and know when to ask for help. A lot of the primary care providers I worked with were wonderful, and they are very open to contact me when they have questions. We do our best in the match clinic to answer those questions, so they come quite often. So I'll give you a few final thoughts. It's important to talk about congenital heart disease care. It's important to talk about making it to 18, surviving to adulthood. I don't personally feel that that's good enough anymore. I think we need people to live well into adulthood and thrive. And that comes with more complicated first life, like bigger surgeries or pregnancy. Not for everybody, but it is something that could be a big challenge for people, and it needs to be planned. We're left with, okay, well, who needs a specialist when they're not? Ideally, adult congenital heart disease specialists should have fellowship training and should follow these patients. Should all be seen at least once, if possible. And they do require lifelong care. There is no cure. You may not need to be seen every year, but there needs to be some connection to ongoing care. And because there are more patients with congenital heart disease that can be followed by specialists, hospitals, healthcare systems need to reflect on that, recognize it, and help address it with resources. This is where that shared model of care, having general cardiologists, general practitioners, even internists, can help care for people, so we can provide them the best quality of care with the resources that we have. So in summary, there are many congenital heart lesions with a large spectrum of complexity. Surgical repair is not curable. And it is important that we understand the anatomy and repair, because understanding the potential complications is very important. We know what to follow and how to follow it. And specific lesions need expertise. So I will leave you with any questions if you have them. And I think we have another speaker that's going to.
What are discussions by all means?
I'm happy to take it if there are any. Or not. Oh, yes.
Quick question. So I see that number of adult patients with congenital heart disease is increased. Is that because the pediatrics are?
Yes. So it's twofold. So the first is that there's a larger number of pediatric patients that are surviving into adulthood. So that is one thing. The other piece to it is that the adults that have congenital heart disease are now living longer. There's more surgeries, more interventions, more medical therapy. So that we're getting it from more people surviving, less surviving longer. But what we've found is that with that more surviving longer, there is more potential for problems as you survive longer, reinterventions, heart rhythm issues, stroke, heart attack. And then they have to deal with all of the everyday heart problems that the average Canadian and North American have to deal with high blood pressure and heart attack as well. So it leads itself to great success, but I feel like we can't just celebrate hitting 18. We need to continue working. I don't know, we're asking for more than a miracle, I guess, but here we are. Any other questions? Okay, thank you so much for your attention. I really appreciate it.
Thanks so much, Dr. Dukas. That was a fantastic talk. I really enjoyed it. So up next on our list of presenters, we have Carol. Now, I first had the pleasure of meeting Carol a few years ago. She is our person with lived experience. So a PWLE is what Heart and Stroke likes to refer to this group of patients or people as. And so from the very first moment that I met her, her vibrant personality shone through. She exudes positivity and energy that is truly infectious. You can feel her presence as soon as she walks into the room. Carol has called Winnipeg her home her entire life, and when she's not teaching as an instructor at Cycle, you can find her enjoying her cabin, brunching with friends, or cheering on her beloved Blue Bombers. So go Blue. Carol is dedicated to raising awareness for the world of congenital heart disease, and she's become a true advocate for those living with CHD. What makes Carol truly remarkable is how she takes her words and turns them into action. Last year, she organized a fundraiser at Cycle where she raised over $1,000 for heart and stroke, and she's determined to exceed that goal in 2025. I'm excited to hear Carol's story of living with congenital heart disease. So please join me in welcoming Carol.
Thank you so much. I'm going to give this slideshow the world, but no promises. Okay, good morning. Thank you, Don, for that beautiful introduction. It's actually afternoon now, I think already. My name is Carol. I am a wife, a mom, a small business owner, a part-time spin instructor, a 31-year bomber season ticket holder, and a congenital heart disease patient. I would first like to say that I am not a doctor, nor do I play one on TV, but I would love to use our time together today to tell you a little bit about my journey with CHD. I was born February 11th, 1975. That's right, if you're good at math, I turned 50 yesterday. I was born at Grace General Hospital to my young parents, Garth and Kathy. Almost immediately after birth, I was turning blue, and at 1 day old, I was transferred to Children's Hospital here in Winnipeg with a suspected hole in the heart. After much testing, my parents were informed that I actually had a very rare congenital heart defect. My right pulmonary artery was coming from my aorta. It would need to be removed and connected to the main pulmonary artery. A complicated open heart surgery that had only been done 3 times here in Manitoba, and I was given a 4% chance of survival. There's me. Spoiler alert, I survived. So at 2 weeks old, the incredible Dr. Cohen and Dr. Cumming, with their help, I survived. After a few weeks in the hospital, I was discharged and able to go home for the first time. I would have an angiogram at 3 months, and again at 6, where it was confirmed I had severe stenosis in the right pulmonary artery. When balloon angioplasty became an option in 1981, at the age of 6, Dr. Cummings suggested that we attempted to try to treat the stenosis, but unfortunately the scar tissue was too tight and the balloons kept breaking. The doctors wanted to try again, but my tired parents decided I was functioning fairly decently and did not want to try again. Growing up, of course, I knew I had had open heart surgery, but there was never a CHD label attached to it. There are so many differences with patients born in the 60s and 70s than now. We didn't have any of the knowledge we have today. There were no books or support groups or even the internet. We struggled to find others like us. I can't help but be amazed at how far we've come, yet so encouraged at the fact that we are just getting started. I never really did feel that different growing up. I mean, I knew I had a big zipper scar, as my grandma called it. I knew I struggled to keep up with my friends, that I would wheeze if I was exerted. But that was all my normal. I didn't know any different. In fact, it's only really been in the last couple of years that I've been able to piece together my story and parts of my own diagnosis and the extent of my own CHD. And a lot of that came with putting this together for you today, so I really want to thank you for that. I think I've had a whole misconception about my own CHD and the complexity of it. I don't think my husband knows. That's not going to help the crowd. Okay. All right. I don't think I gave it the validity it deserved. Was I too hard on myself at times? Or did I accomplish all I have because I had that perseverance and that resiliency inside me? If I had been more aware of my own diagnosis, would I have been less hard on myself? I hate all the times I was hard on my body. How could I be so cruel to a body that had continued to fight for me so hard? But part of the beauty of aging is the perspective you learn. I can look back now with this new amazement and be like, wow, I really did that. I took my 4% and I built an entire life. I graduated high school, I got married, I had 2 children. I built a 30-year career when people along the way doubted me. I was able to buy a house and later a cottage. I got to cheer on my team while they won and unfortunately lost breakups. Sure, there was challenges and insecurities along the way. I spent years covering up my scar, never wanting to wear a bathing suit, without a t-shirt on a school field trip or at swimming lessons. I would never wear V-neck shirts. And I remember purposely trying to buy a wedding dress that wouldn't show too much of my scar. But now I embrace it, and I hope you do too. I want you to wear it like a badge of honor, of not of everything you've been through, but of everything you've survived. The shortness of breath, well, that's still an insecurity that is a work in progress. I have been asked my entire life, do you have asthma? I don't, but I didn't know how to answer it. It was something that I was just starting to try to understand. And because I'm fortunate enough now to have a cardiologist again after almost 2 decades without, I am getting better about just being transparent and forthcoming with my insecurities. Because the more you embrace your insecurities, the more it erases the shame and replaces it with pride. You want to meet and go for a walk? Sure, but just so you know, I'm short of breath when I walk and talk. See, because what I used to do was hold my breath until I could regain control of my breathing. I did that my entire life, and the worst part is I didn't even realize I was doing it. And let me tell you, it takes a lot of practice to change something you've done your entire life. I wish these challenges had been addressed more for me, and maybe with more consistency and care they could have been. I think that continuity and care is vital for us all to reach our full potential. The more now I learn, the more I realize that it is wild to me that I didn't see a cardiologist with my pregnancies. But it was 30 and 25 years ago. Oh, I forgot the slideshow. See, I told you. Dawn, this is too much. But it all worked out. It's just another reminder of how lucky I am. Here's my kids. There you go. Oh, that's me and my kids. That's me and my kids. Yeah. Quality of life is a term you often hear in the CHD world. And I always thought, yeah, I'm doing well. I eat, I sleep, I work. But what I've learned is that's not quality of life. That is merely existing. Quality of life is getting to do the things you love that bring you joy. Sure, we may have to modify and navigate it a little bit more than others. I know not all of our circumstances are the same. I know that we are unique and that no two of us have the same sets of symptoms, side effects. But I think if we can continue to fight for the awareness and advocate together. My hope is that we can all find a little joy in this unique battle we are fighting together. During a routine physical with a former GP, I remember he listened to my lungs and he said, "I don't know what's going to happen to you." He didn't offer anything more. My childhood cardiologist that I had seen once every 5 years growing up had long retired. I was now in my early 40s and his words loomed large. It was lonely and scary, but it did fuel me to prove him wrong. So I decided for the first time in my life, I was going to try to do some sort of cardio. I couldn't find anything I loved. And then in 2018, I'm gonna skip back, don't worry. In 2018, I tried to spin class. I was petrified, but I signed up and I went. I hated it. I was so weak. I couldn't do anything the rest of the class was doing. There was no exit door. Trust me, I checked. Plus, I knew if I left, I'd cause a scene. So I just sat there and I pedaled. And after class, I told the instructor that she was adorable, but that I would not be returning. But I did what I've always done, and I kept going. And that one class turned into 100, which turned into 200, and I was getting stronger. I was still last in almost every class, but I was doing it. Sabrina, you're so sweet. My doctor. I was now around the time that the instructors who were now my friends were asking me about when I was going to start instructing. And I always laughed and said, yeah, maybe if I was 20 years younger and I didn't have a heart condition. But secretly I wanted to, and that desire only continued to grow. But I thought, no, that's impossible. I was 47 at the time. I mean, come on. But then I watched my favorite female curler, my idol, who was the same age as me at the time, qualify for the Olympics. So I was like, wow, if she can do that, surely I could be a spin instructor. So I signed up and I took the next training. I did 8 weeks of training, an audition, 3 team teaches, and I got a spot on the schedule. I started to build up my time slot. My classes grew and I loved it. But what I wasn't telling anybody was that I was struggling. My heart rate was going over 200 beats per minute and a slew of other red flags. I knew I was having palpitations, but I didn't know what was happening. And then I started to get alerts on my watch that telling me I was in AFib. I found a new GP by this point who I love and who advocated for me. And luckily, I was now a patient at the Adult Congenital Clinic here at St. Pete. But I was so scared to tell her what was going on because I just worked so hard at my own training and I didn't want her to shut it down. Spoiler alert, she did. She didn't want me cycling at all until I was able to get cleared from my cardiologist. I was devastated. But like a miracle, Dawn called me. And not to sound dramatic, but I feel like that my life changed in one phone call. I had been so overwhelmed and so isolated with my own symptoms. I was so scared of what was going to happen to me. But she listened to me. She had answers. She had solutions. She prescribed me beta blockers right away to try to control the arrhythmia. And more importantly, she assured me that I could keep spinning, which was important to me. The team there were a huge support system for me, and by now they were some of my best friends. I slowly filled everybody in to make sure they knew that they were aware of what was happening. I had to get a few classes covered while I had an angiogram, but they continued to support me. We even ran a heart and stroke fundraiser as a challenge through the studio last year, and we were able to raise over $4,000. They helped me design a whole new class style built for people with limitations just like myself, and we added it to the schedule once a month. I am so grateful that I had the Adult Congenital Heart Clinic to turn to. What would have happened to me if I hadn't? Because for me and so many others, we didn't always have it that way for so many years. I didn't have a cardiologist for close to 2 decades. Bridging that gap from pediatrics to adult care is so important, especially as we age. The long-term side effects of CHD and potentially new symptoms can arise, as was the case for me. In the last couple of years, I've had a bunch of tests. We discovered that my right pulmonary artery is fully blocked. My right lung is small and underdeveloped, and I'm slowly functioning on the left lung. I had some pulmonary hypertension and a risk of stroke because of all the arrhythmias. So last January, I had to go on a few different medications. That was a rough day for me, but I also respect that the medications help me. There's still days where I'm unstable. I still get AFib, but it's less, and I monitor it and I listen to my body. I work really hard to control my heart rate, and it allows me to keep exercising. As it became more evident that there was no real treatment plan available to me, that currently the risks just outweigh the rewards, I decided that I was going to turn my attention to being an ally and an advocate. I knew Dawn was working very hard to get this event together today, and I wanted to help. I had more like handing out pamphlets and cookies in mind, but hey, this is what to do. And lastly, I want to finish with this. Please talk amongst yourselves. When people in the past have asked me to share my story or write a testimonial, I always thought that I don't have a success story. But what I realize now is that this is my success story. I am my own success story. That being here today and hopefully helping even one of you is my success story. To know that you are not alone. To make one person more aware of CHD, that is my success story. Or that I took my 4% and I built a whole life in spite of my congenital heart disease is my success story. That inspiring others with the classes I teach and the friends I've met along the way. This is my dad. The friends that I've met along the way, that being a wife and a mother and hopefully your ally is my success story. Because how lucky are we? How lucky am I? Thank you.
Thank you so much, Carol. That was absolutely so moving. Very honored to have heard your story and the challenges that you faced. With that,
So I would like to welcome up our next group of speakers. We're going to have a couple of people that are speaking from the Circle of Hearts Family Support Network, which is an amazing group of people that have kind of built themselves together to support our kids and our families that are going through this heart journey. They've done everything from family support to peer support to having camps for the kids. It's been an amazing journey. So our first speaker is going to be Kristen Miller. She is secretary for the Circle of Hearts. She is heart mom to Jackson, her 7-year-old heart warrior. And following her, we're going to have John and Rhiannon Blatcher come up and speak. They are members of the Circle of Hearts support group, and their son is just approaching the transition stage.
Thank you everyone for coming today. I didn't know what to expect today, and I'm very happy to see all the chairs are filled. I want to thank Heart and Stroke for allowing us and connecting us with Circle of Hearts. We're a very small group in the grand scheme of things, and I think this past few weeks with CHD awareness, our Instagram and Facebook profiles our insight has reached drastically over 1,000%. Our followers are increasing, and I really want to thank Carol for sharing the interview she did last week, because that has also increased our reach as well. And I'm just very grateful that we're becoming aware of CHD within Manitoba. When I was 20 weeks pregnant, I learned that my son Jackson might have a heart condition. I was desperate for information and support. I turned to Google and found Circle of Hearts. Reading the stories of other heart warriors provided me hope. However, we did not have a confirmed diagnosis. I felt lost and uncertain about the future. I tried to focus on enjoying the rest of my pregnancy. At birth, my son Jackson was diagnosed with hypoplastic left heart syndrome. And as we have been talked about earlier, that's one of the most complex heart disease you can be diagnosed with. It was far more severe than we initially expected of a VSD and a coarctation. Instead of the minor concerns we were told about, his condition was critical, so much that he was life flighted out to Edmonton at 8 hours old. I'll never forget relaying all this information as my husband passed on to me and Dr. Buffo tried to explain what was going on and tears just streamed down my face. In that moment, I couldn't even process a word he said as I tried to grasp what was happening. Because of his fragile condition, Jackson underwent his first open heart surgery at 2 days old. Walking into the NICU, I felt completely lost and overwhelmed by the sight of so many sick babies. As Jackson grew stronger, I revisited Circle of Hearts and considered joining their private Facebook support group. However, before I could, his health took a turn for the worse, and at 5 weeks old, he was listed for a heart transplant. During this time, I avoided most online support groups for my own mental health. I only wanted to hear positive stories, and when your child's life is depending on someone else's, I could not fathom to hear any negative stories. In January 2018, we finally flew home after 92 days away in Edmonton. I thought we'd be home for a few months and have the Glenn surgery in a few more months after that. However, 2 weeks after we arrived home, he went into cardiac arrest. My husband and I did the unmanageable and performed CPR to his little 10-pound body. That next few weeks was unreal. He went into cardiac arrest 4 more times and was medically paralyzed to be kept alive. I started to plan Jackson's funeral in my head, and I did not know what to expect the next hour. Desperate for connection, I finally clicked join on the Circle of Hearts Facebook page. On January 29th, 2018, in the early hours of the morning, I made my first post as Jackson was in the OR receiving his new heart. The outpouring of support was immediate. It was exactly what I needed, a community who truly understood the realities of living with CHD. In Jackson's first year of life, we had a village supporting us in countless ways. I knew I had to give back to the community that helped us so much. However, I thought about making my own charity. However, given Jackson's age, I was not in the space to do that. In December of 2018, I attended our first Circle of Hearts event. It was the family Christmas party, and I felt called to give back. The next month, I officially joined the board, and I have not left. At this time, Circle of Hearts was planning a fundraiser, and as I jumped in, I took on more responsibilities. Today, I serve as the secretary, manage the social media, and wear many other hats within Circle of Hearts. Giving back through Circle of Hearts has truly been life-changing. I once considered starting my own charity, but Circle of Hearts had the foundation in place. I knew I could make a bigger impact dedicating my time here. Over the past 6 years, Circle of Hearts has enriched me tenfold with friendships. That's the biggest thing I can say. I have formed many friendships over this journey. The heart moms and dads in this community truly understand our life. They supported me through hospital stays, brought me emails to the ER, sent gift cards while we were in Edmonton for Jackson's heart caths, and watched my daughter during appointments. I've never had to explain our struggles. They lived them too. What started as a support group for me has grown into some of my closest friendships. Connections have not only just been vital for me, but for my entire family. Now 7 years old, Jackson has only ever known life with Circle of Hearts. He attended his first camp before he was even 2 years old and has been going every year since, with the disruption of COVID that obviously impacted it. And at camp, we watch him grow, thrive, and build bonds with other heart kids. It's our family's favorite weekend of summer, a place where scars are normal, medications are routine, and where we can experience activities that might not be possible outside of this unique community. For my daughter, Annika, who is 4, she loves being a heart sister, and she takes this role very seriously. She has so much empathy for Jackson and loves wearing clothing with hearts on it, proudly embracing her special role, heart sister. She actually just told me last week that she's going to be Jackson's heart doctor when she's older, and he will be her only patient. She loves the fun events that include siblings, recognizing that this journey affects them too. Circle of Hearts understands that siblings are just as important as the heart child. My title of mom quickly changed to heart mom, and it's a title I proudly wear. Shortly after Jackson was born, I had to adapt to this new life. The advocating and spreading CHD awareness began immediately. Circle of Hearts has provided me a platform to raise awareness, share our story at events, and create connections I would never have done otherwise. I truly believe everybody should volunteer in their lifetime. Circle of Hearts has gifted me opportunities I never imagined I would do. I am driven, determined, and use my personal connections to better this organization. Giving back has not only allowed me to help others, but also helped me grow in unexpected ways. From grant writing to event planning, I've gained valuable skills while making a real impact on all families, specifically for the kids. I do it for them. They deserve a life full of fun and excitement, and acknowledge that being a heart kid does not define them. I'm truly proud to represent Circle of Hearts and the heart kids in Manitoba. Our reality of the CHD community is that not everyone has a happy ending. In September 2019, that reality faced us. As a board, one of our heart families lost their daughter. It is with a heartbreaking reminder of how much CHD can be cruel. As a board, without hesitation, we stepped up, honoring Peyton's favorite things, colors, and animals at her celebration of life. It was truly an honor to help a family in need during a very trying time, not only for the family, but for us as a board and a heart community. Circle of Hearts is there for the highs and lows of this life. When I was approached to give this speech, I could talk about hours of what Circle of Hearts means for me. However, I'm just one of many. As we know, over 6,000 patients are seen a year. I reached out in our Facebook group and was flooded with messages and responses about how Circle of Hearts has impacted them. One family remembers Dr. Stoney visiting them in the early hours of the morning, explaining the child's heart condition. In that instant, they realized that the heart center was not just a medical facility, it was family. And with that, introduction came to Circle of Hearts. Before their journey, they had never even heard of CHD. They watched others welcome their newborns home within days, while they remained in hospital navigating surgery, setbacks, and uncertainty. It felt like an entire chapter of their lives had been taken from them, but Circle of Hearts has changed that. It's become a source of comfort, reminding them that they were not alone. Shared experiences, understanding, and support from fellow heart parents made all the difference. Talking to someone who has walked the same path carries a depth of understanding that someone else cannot provide. Circle of Hearts has provided lifelong friendships, and a community has grown, a place where heart parents don't just think about their own children, but every child facing this journey. Some of their darkest moments in the hospital has slowly been replaced by the joy of memories provided by Circle of Hearts. For another parent, Circle of Hearts provided a safe space to ask questions, process their child's diagnosis, and the reality of during this immense change. It became a place of acceptance and belonging. Their child, who was once believed they were the only one with a broken heart, discovered an entire community of kids just like them, children with scars, medications, and shared experiences. That realization for her was life-changing. Circle of Hearts has been offering the support for nearly 3 decades. One of the founding members recalls how isolating it felt when her son was born with hypoplastic left heart. Krista and Tyler are here participating, and I want to personally thank you for creating this group. No child should have to go through this alone, and no parent should have to go through this alone. She created Circle of Hearts to ensure that no family would go through this alone. Today, Tyler is proof that there is hope for children with CHD. Thank you to Krista, Meg, and Karen for creating this organization. It has truly changed our lives within the CHD community and providing a platform for so many of us. Circle of Hearts hosts many events throughout the year, including family fun nights, hay rides, youth events, family and youth camp. That's a family favorite for many. It's personally my favorite. I can attest that my son Jackson was G-tube fed for the longest time, and it was at camp where he started to drink a water bottle orally because his peers, another heart kid, had said to Jackson, he's like, why don't you drink water? And he says, because I don't. And that weekend changed our life because of another heart kid's support. And it's just moments like that that really validate why we do what we do. And it seems so minuscule in the grand scheme of things, but it was a huge part in our journey to finally get orally drinking. And we also provide first aid training, CPR, which we're having in a few weeks. And we also host our holiday party with Santa. However, despite these experiences, we're always looking for new families to join. We're quite small in the grand scheme of things. We maybe have 300 to 400 people that we reach out to. So with our public social accounts now, we've increased a lot more. And I hope that in the coming years with this event at Heart Stroke and just having the collaborations with everybody that we do increase our numbers and reach more people. So Circle of Hearts is more than just a support group. It's truly family. It's a place of understanding, connection, and hope. For families facing CHD, it's a reminder they're never alone. Or do you want to do we have my PowerPoint slide. I can just do it. It's like 5 slides. Sorry, did you see it? My husband did a PowerPoint presentation for me yesterday while at work. That's some of our heart kiddos at camp and our hay rides that we typically collaborate with our AGM in the spring. If you want to follow us on Facebook and Instagram, I highly suggest you pull out your phone and scan the QR code so you can follow us. We are trying to reach, those are some of the CHD kids that were at camp. My son is the boy in the middle, small one in the white shirt. And one of our favorite things at camp is we've kind of dubbed it Blueberry Island. I'm not sure why. We find raspberries, blueberries, and other things. So all the kids get in kayaks and canoes. Some of them who are not able go in the boat, and we head out to an island and we find what we can and make an adventure out of it. That was last year at our holiday party. And we have family fun nights. We try to do about 3 or 4 of these a year, and it's literally just an open gym with kids having fun. We hosted one a couple weeks ago. It was a small amount. There's only about 5 families, and the youngest one was 2, the oldest one was 10, and nobody wanted to leave. It was 9:30. We begged the kids to leave. And that is another camp picture too. And we're very fortunate. Sean Knox, who's an adult CHD kid, not kid, but he has a drone, and he always loves taking pictures and videos at camp for us. So we get these awesome shots. A plug here, we have our fundraiser coming up next month on March 20th. I have tickets with me if anybody's interested. And this is our biggest fundraiser. We do have one planned for the fall again, but it's gonna be on a lot smaller scale. And basically this money helps us pay for everything else up on top of our grants that we receive. Thank you.
Okay, we will welcome up John and Rhiannon.
So everyone else's presentation was a little bit more prepared and planned. Ours is going to be a little bit more ad lib. We talked for about 5 minutes last night at 9 o'clock about what we're going to speak about, but thank you for those that have shared their stories. I got 17 years of emotion, so I'm going to try and get through it. Kristen is the driver of Circle of Hearts. Thank you for everything you do. We do have a board of about 14, 15 that do put in a lot of time, but Kristen does drive the group and does make sure we're on track and we're doing what we should be doing and want to do. And thank you for all the efforts that you do. And I started the board about the same time she did, a little bit earlier. I'm the treasurer and average webmaster. I'm going to just let Rhiannon talk a little bit about our son and kind of a little bit about what we've gone through. And then I'm just going to talk a little bit about and maybe ask more questions about what's next for us is kind of what we wanted to present.
Thank you. The big thing here, I think John and I will probably go back and forth between who is going to cry. So we'll try to get through it. It's interesting, like as John said, it's been a 17-year journey for us, and I'm normally fine living, going through normal life. And my son Jackson, which is another Jackson, normally drives us crazy because he's got so much energy. But the moment I get into these things, I just start crying. So just a little background on our Jackson. In terms of some of the medical background and that was provided, that was fantastic about congenital heart defects. John and I were thrown into that and learning so much about the heart in that one day on my 20-week ultrasound when we found out that our son, or at that point we didn't know the gender of our child, had a significant heart defect. And in that one day, which truly was at that point the worst day of our lives, learned so much about what was to come for us. We were told, and in the one day we visited the heart center, we visited the nurse, we had ultrasounds, we had an amnio, we visited a neonatologist, and we're basically told while I was pregnant at that time that we didn't know if our son would live. And in the journey that happened, I hoped at that time, I actually did a whole bunch of visualization, thought that somehow that extra chamber would grow. But I was told that after 8 weeks it wouldn't. So a little background about Jackson. So our Jackson was born in 2007, and we knew that he likely would have hypoplastic left heart. He was born in here in Winnipeg and flew about 5 days old to Edmonton on a medical plane and went through a whole bunch at that time
them trying to figure out even more what was wrong. I think here in Winnipeg, John and I just kept thinking to our hearing there was more. He doesn't have a spleen. He doesn't have this. He doesn't have that. We were at that point where, when is this going to stop? When are we going to find out everything? So our journey, and I'll summarize it quickly. Basically, he had the Norwood. It's the very first surgery. So when we talk about, your heart defect is serious when it's named after someone, we have 3 of those. He had the Norwood when he was 10 days old in Edmonton. It went okay. We spent 2 weeks in Edmonton recovering, came back with our new baby that was very blue. Jackson has always been very blue, but he was very blue. And I think, bringing him home, and my grandparents were just a little bit nervous to hold him. He was very blue. So 2 weeks after getting home from our Norwood, they flew us back out to Edmonton to get a heart cath, to see why he was so blue, to see what was happening there. So he had his heart cath. Everything was going fine. I had not had a lot of sleep. John flew back home. He had a meeting, and we thought things were fine. And that night he had cardiac arrest. So I got the call. I was at the hotel the one night that I went to sleep. He had the cardiac arrest, and I'm running, basically my mother-in-law running down the streets in Edmonton to get to this. So Jackson, after going through the cardiac arrest, we were told he likely wouldn't survive. They put him on ECMO. So we've learned, as I said, we learned a lot about all this very quickly, and we didn't really want to, but we did. He was on ECMO for 3 days and somehow pulled through. And then he had his Glenn at 4 months old. We lived in Edmonton for 4 months, had his Glenn, came home, finally brought home our baby, as I felt at that point after having his Glenn. We brought him home actually on February the 14th when he was 6 months old. So that's this Friday, 17 years ago. From there, it was really interesting. It was so impressive at how he hit all of his milestones very well, actually. Like this little boy that they didn't think would survive. We were in Winnipeg. He was doing his normal things. He walked at a normal age. He was talking at a normal age. It was amazing, like amazing how resilient he was. And also truly the support and that we felt from the heart center here, and also from the amazements with modern medicine and what they could do in Edmonton. So at 3 years old, 3.5 years old, he went and had his Fontan back in Edmonton. That went fairly well. And since then, he has basically lived pretty much a normal life. The only challenges that Jackson's had, on top of everything else, because of the cardiac arrest that he had, he has ADHD. We figured out he has autism, and then he also has a cognitive delay. So all of that as a result of everything. At this point, though, with Jackson, he's still quite blue. His oxygen levels still sit at 85%. We go back to Edmonton a few times a year, a couple times a year, maybe once a year sometimes, to get heart caths, more, I think, a bit as a little bit of a Band-Aid solution at this point, where he likely probably will receive or will need a heart transplant at some point. But we, as John will talk about here, and I'll transfer to him shortly, Jackson is 17, he's in grade 12, and we're at that point right now where we are going to be transferred to adult care. And it is terrifying for us because the nurses and the doctors, and we've had Dr. Soni the whole time, we've had the fantastic nurses at the Heart Center, they are like family. And the thought of moving and taking this gigantic file of items for Jackson and transferring it to a new doctor is very scary. And that's why we want to be part of this. So I'll transfer this over to John just to talk about it.
Yeah, and I think part of that is also just the reassurance and the comfort that we've come to appreciate with the Children's Heart Center here, but also the Western Canadian Heart Alliance and the network of care that's been provided to Jackson over the years. So now we're going into something that's really unknown. We've been told by Dr. Soni and the team at the Heart Center that we will be transitioning. He's 17 now. He'll turn 18 in October. We do expect him to go to Edmonton 1 or 2 more times during that time. We really just, as Rhiannon said, have a lot of uncertainty now. And we know that there was a presentation and that he will be in good hands coming over to St. B into the adult care. But there is a lot of questions that we have and that we're going to be going through over the next 6-8 months. So there's questions that we don't know much about this process at current time. When will that start? Who will we be handed over to? Who's all involved in this transition of I'll call it, what was the terminology I used? The transfer of knowledge, or the transfer of Jackson's medical history. Who's all involved in that? Jackson also has an intellectual disability, as Rhiannon said. So how does this factor into his future decision-making for his health care? As we do expect significant ongoing care that will be needed for his heart. He's also not gone through puberty yet. He's barely a teenager in that sense, and he now will be going over to adult care. When will we get a chance to meet the new care team? I also want to just share right now, if it's okay, I did ask one of our fellow Circle of Hearts parents who has recently gone through the transfer. It's Shannon Trickett and her son Marcus. So Marcus is now in adult care. He's did go through the Heart Center. So this is just some comments that she provided. She texted me last night, so I'm going to read from my phone. So it is a lot harder than I imagined to move to a secondary caregiver and trust and guide to my child to take over primary care. For some procedures, we parents are usually asked to wait outside, echoes, caths. That's not what they had normally done. They were always there in the room. So common sense, but nothing we realized until it happened. So again, that's something that's going to be a little unique with Jackson, with his situation, that we're going to find out about. Ensure your child has a credit card if he or she is going on their own. These are things that we wouldn't even think about. There are not many cash debit options, even for things like parking. Manitoba Health is the child's own card. They must apply right away for pharmacare deductible. Ensure they do their income tax at 17 no matter what, so it's valid. Although your child doesn't magically change on their 18th birthday, health mandates, hospital and medication protocols do. For example, time between appointments, caths, changes in medication and doses, all of that. It's kind of now in Marcus's hands, and although Shannon drives Shannon crazy, but she's willing to accept it.
I want to just thank everybody here. I think coming here and being in even the St. Boniface Hospital, I was thinking as I drove in here, all of our significant care of the surgeries that we've had have been in Edmonton, which involves, the support from the Heart Center here and flying there and staying in the hotel. And the thought of moving over to here and being in the same city is fantastic. I think that's a positive in that. But I also, as we end this, I just want to really thank the Heart Center and the Circle of Hearts as well for the support that we've been given. They are like a family, and we're looking forward to kind of transitioning to a new family in the adult care as well. And I feel very, very lucky to have those opportunities here in Canada, and knowing too that we have I think that was one of your stats. I can't remember where the stat came from. I think it was from you, Pam, that we have one of the best cases of success for single ventricles. I think that's something to be so proud of. So thank you so much.
So I just have a question for Kristen and John Rhiannon. So with the Circle of Hearts, I know it's all focused right now on peds. I work the adult world. Are you guys looking at expanding potentially and continue to include these people as they grow into adulthood?
We haven't discussed this fully as a board. I've talked to other members of it too, thinking that maybe we can have like coffee nights or something that we can just connect with. I think Carol would be a huge advocate for the girls of CHD. I know the one girl that I spoke of today in her story, she still is very sensitive of her scar. She will not wear anything that shows it. When she came to camp, she was actually blown away that there were other kids just like her. And so I think that we can do some collaborations with adult CHD and that should maybe be able to take a breath off.
And I'll also add, like, we also we're also trying to include some of the, like, we'll call them kids.
Yeah.
I still call them kids. They're 30 years old, they're still kids.
They're transitioning from youth adult care, become part of the board, Brady's part of our board, in a sense, it was not.
Yeah.
But we're trying to engage them longer term.
And a lot of, yeah, and a lot of our youth camp, when they go to camp Monday to Saturday, it's typically the young adult CHD kids that are counselors that give them opportunity to navigate through that peer support for the younger kids.
That's fantastic. I look forward to seeing the growth that you guys can have. I know when we had our Fontan Day, it was really cool to see some of the people living with Fontans being able to connect. Because there is no support group when they when these people grow into adulthood. So it's fantastic, and I look forward to seeing what you guys can do. Can't find my mouse. There it is. Oh, Elson, I hit the wrong one. That's okay.
We're medical, not technical.
Yeah. I just
Back to your previous slide.
yeah to ours.
Yes.
To mine.
I'll-
You'll get it. Okay.
So we've moved on to the fun part of the afternoon, where we're going to do our prize draw. Let's wait till we grab our basket. See who our lucky person is.
This is good.
That's perfect. Okay. Let's make this official. I'm going to pick somebody out of the audience.
So which one are we drawing for?
Which one are you going to do first?
Heart and stroke. I have it in your hand. We have a little prize pack generously donated by Christine over at Heart and Stroke. It's some fun little goodies in here.
Krista Brown.
Fantastic.
This is for the cycle pass.
Yeah.
Okay. Linda McLean. Woo.
Yeah, well, so we'll try to get that. She works here, so fantastic.
All right, thank you. Excellent. Okay. So first off, we want to say a big thank you to everybody that came out today, for all of our speakers today. Honestly, this program couldn't go ahead without all of you. So when we look towards next steps, things that we would like to see accomplished, we would like to see transitions start at a younger age. We would love it if we could start this conversation at like the age of 50, so we have some time to talk about it before we get to that age of 18 where we're transitioning you.
And then go into the early 20s to continue that growth.
To continue that support more than what they get so that we don't have that loss to follow up. To look at things like building more allied health into our programs so we have the support of mental health workers and social workers and everybody to help them navigate that. Because as all of us can attest, because we've all been through this stage, suddenly becoming an adult is not an easy process at the best of times. And then if you add on health concerns on top of it, it gets very complicated very fast. So we would like to see more supports in place and to kind of build that team around them, to focus on more awareness events like this so that people will understand congenital heart disease is not a kid-specific thing. This carries out through your lifetime, and you'll have different needs across the lifespan that we need to address. So we just want to thank all of you for coming out, thank all of you for speaking. We appreciate that everybody had a chance to come. Please make sure that you grab a cookie on your way out. Whether you want to be a cyanotic heart or a normal heart is totally up to you. But again, thank you all for coming. All right, so again, thanks everybody. Make sure you help yourself to some water and coffee if there's any left, and help yourself to a cookie on your way out.
Yeah.
Okay, was that both the others?
I just wanted to come and say hi and thanks for putting this event together. I'm a PhD student and I'm this hormones. Yeah. My name is Tasha.
Glad you were at the event.
Hello.
Barry. This is why things like this are really
Of course.
I'm gonna put my camera. Hey, you won. I know it. Yes. She lives in West Brand. She goes by the house. Passport together. Very hard. Very hard. She's like. Yeah, I had to leave for the family talk as one of the taxes texted me with. It's free. It's free. That was a really big ride. You know, and I think like for us, just now with the I had 6 months. And I'm trying to work that out of the consequence of life there. I think what instead of just thinking about the various, oh, no, we don't have a find a way to work around it. Yeah, like how do we make it work? And if we all have someone today that's urgently, then maybe tomorrow, and I have to jump with someone and have an extra so I was gonna put so AGM is coming up, and last year I was expecting it. And I thought you consider like that, you know, I don't want to put on this one May 3rd, Saturday. Like Saturday morning, but I'll shoot through that again. But I think it would be great to have a talk about this. Robin's done like a very technical presentation. Which is great, but I think different that's great. Thanks so much.
Okay, I'll be right back.
Okay.